areas of the different diseases you can look out for bowel, not so much bowel cancer, but colitis and Crohn's and everything else as well. But we've got another guest coming back on, and we're going to talk surgery, aren't we? Nahu?
We certainly are.
Yes. Okay. So where do we start? And that's a leading question really, because obviously you've got to find out where the problem is first before you can make a start on it. But surgery is obviously used is the primary way of dealing with, is it just cancer or Crohn's or colitis as well?
So I'm going to take a few steps back and talk about how to actually become a surgeon.
Okay.
Because what's really important, I mean, at the moment I'm nearly finishing my training, but I've decided to start to do research, which I talked about a bit earlier, and then go back to training. So I've got 2.5 years to go before I'm a consultant surgeon. And what's really important, a very important quality in a surgeon, is to know not just how to operate, is to know when to operate, but most importantly when not to operate. So when we just talked about operations, it's quite important when that consultation is happening and when somebody's in clinic or you're seeing them on the ward, is to decide whether this is the correct operation for the correct person. And then it's a two-way process, Keith. So if somebody comes up and they've got something wrong with their bowels, then we take what we call informed consent. So I would be talking to somebody saying, this is the operation that I think you require, however these are the pros and these are the cons and these are things that could potentially go wrong. However, at the end of the day, giving you all of the information with regards to the procedure, then you will make a decision whether you would like me to go ahead or not. So that's what's really important to start off with.
Okay, so we've got to that stage, and obviously when you're looking at a diagnosis or a treatment, you need to decide whether, particularly around cancer I suppose, if it's the surgery is required first or the chemotherapy is required first, because obviously from my own personal experience, they operated on me first, and then the chemotherapy was to enable the next operation to happen. So it kind of reduced the size. So is that part of the planning process when you, all patients are different, but I suppose.
Indeed. So if we're talking about cancer, if we're talking about non-cancer, so even inflammatory bowel disease, what's really important is that the surgeon never operates on their own. They never make the decision on their own. It's a team process. So you'll get the specialist nurses, we will hear from one very shortly. We get the gastroenterologist, you heard from a couple earlier. And the radiologists are very important as well. So we have multidisciplinary meetings where a decision would be made based on the endoscopy, the imaging, and everything. So it's a story. So we say the story, and based on that story, we decide whether an operation needs to be done first, whether this doesn't need an operation, whether it can be removed by endoscopy, for example, or whether medical treatments such as chemotherapy or just other medications need to be done first. If the decision is made that an operation is required, then it's a question of, is it going to be done keyhole or is it going to be done open? Or can we do this in a combined, we've got amazing new techniques here at St. Mark's where we're combining endoscopy with laparoscopy, so keyhole and endoscopy to do minimal access procedures, and it means that patients go home earlier, they have a quicker and rapid recovery, and they do very well without massive scars in their abdomen.
You've answered all my questions.
Have I?
Yeah, what I was going to say. It's like, obviously, my own personal thing, they keyhole, and then they open me up a little bit to get the last bit out as well. But I guess that aids the recovery because the less invasive it is, like you recover quicker.
Yeah. So, not every surgeon can do a keyhole operation, and not every operation can be done keyhole. So there are massive operations that can only be done in the open technique. So we make that decision whether it's suitable or not, and then the appropriate surgeon will do the procedure. There is something called the Enhanced Recovery Program, which that's what we currently implement here at St. Mark's, and it basically means that early mobilization. There's none of this lying around for 10 days after an operation. You need to get out there, you need to keep moving, prevent clots in the legs, eat early, no tubes, minimal staying in bed, just to make sure that your gut starts working quickly, and we make sure that your recovery is safe but rapid.
I can vouch for that. The very next day I still had 6 tubes on me. I was out of bed, walking along. I didn't go very far. If I couldn't go very far, I was attached, but you know. But the whole point was you're up, you're mobile very, 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 very quickly as well.
We need to get you back to your pre-diagnosis quality of life quite quickly so that you can resume your daily activities, and that's the aim here at St Mark's.
Okay. Why surgery for you?
I'm so passionate about surgery. I can talk about it forever. However, it started off when I was a baby doctor. So after my 5 years, I'm not going to tell you how long ago that was. Well, I might just. I'm now in my 11th year of training, and I've got about 4 or 5 to go. So it's forever, really. And then I did a medical job, and it was basically giving people drugs and then increasing it by 2.5 milligrams and waiting forever for an effect. And I thought, this life is not for me. I need something a bit more rapid that I can help somebody right now. And then I did a surgical job next, and somebody came with a hernia, fixed it the next day. He was home same day. I thought, this is what I want to do.
This is for you.
Yeah.
Okay. And how long you got to go before you're obviously are a surgeon, but like.
So I do operate, on my own at the moment, but I've stopped my training to do a PhD. Because surgeons actually, contrary to popular belief, are very clever. They don't just operate, they know what they're talking about.
Wow.
So that's why I'm doing a high degree. I'm finishing off my PhD in 6 months. After that, I'll go back and I'll have 2 years to go before I'm a consultant.
My sister-in-law's doing a PhD. Finally, we're going to get a doctor in the family.
Hey!
It's unbelievable. Well, listen, good luck with the research, and good luck with the surgery, and good luck with your training as well.
Thank you so much, Steve.
That's all right. Thank you very much.
Now, final words. It's Bowel Awareness Day, guys. Please stop by. Please ask us questions. We are here from St Mark's just for you. So do stop by and ask any question you like about bowel-related issues. Thank you.
Thank you very much. Not only that, she's my Macmillan nurse. This is even better. No one else is, just mine. Right, so this is Manju, and just tell us, what does a Macmillan nurse do? Well, there's lots of things, but let's.
It's very difficult to say what Macmillian is. It's so much job, so much work to do. We get involved from the point of diagnosis. We like to meet the patients when they are diagnosed with a cancer, and then we become their link person, a main key worker, and then we are with the patients throughout their cancer journey. It could be few days, few months, or few years. And when patients are cured, we are with them for at least 5 years, because we like to get involved and maintain the continuity of the care and help them with their survivorship programs and with their cancer surveillance.
So for example, if anyone has an issue around anything to do with, so it could be appointments, it could be follow-up things, it could be that really the person they come to is the Macmillan nurse.
Yes, we are our cancer patients' key worker. We don't just see the colon cancer patients, we see the rectal cancer patients, colon cancer patients, and the anal cancer patients. We see the patients from the Norfolk Park Hospital, St Mark's Hospital, and also from St Middlesex. So we are the patient's main key worker, and I normally sum up my role as I join up the care from the outpatients when the patients are diagnosed, take them to prepare them for the treatment, from treatment to oncology, for chemotherapy, radiotherapy, from hospital to other hospital like Mount Vernon Hospital for the radiotherapy treatment, to Hammersmith Hospital for liver treatment and all that. Then bringing them back to their surgical clinic appointments. So I run a telephone helpline, advice line service as well. We support the patients Monday to Friday 8 to 4 and help them to answer their questions, queries, and help them as much as we can. We give them as much as written information as possible. Because what happens is when the patients are diagnosed, the oncologists and the surgeons, they can only do so much. When patients hear a word, cancer, when they come out from that room, most of them have just said to me, the only word they could hear was cancer. Nothing else mattered to them. They come out of the room, they have lots of questions. They don't know what to do, what the treatments are, what is chemotherapy. Some of them never even heard the word cancer. So my job becomes to support them, take them through their cancer journey, and help them as much as I can. Not just the patients, but their families.
And I suppose, obviously, at the point when you're in the room and you're there and you have to take the patient away as well. Have you got different ways that you deal with that yourself in talking to people? Because I'm sure, and I've seen this as well, people react differently. Some are quite strong and other people are...
Absolutely. Everybody's different, and cancer doesn't just affect the patients over 50. Like we keep on saying, the cancer is a disease of people over 50 years. It can affect the young people, and it affects the older people. It affects at any age group, really. And everybody's needs are different. Anybody's physical and psychological staminas are different. So we have our ways of supporting the patients and just help them mentally, physically, and we achieve this by doing a holistic need assessment of each and every individual who comes to our door.
And can you help the families as well? Because obviously it's not just a patient, the family has to deal with lots of different things.
Absolutely. When cancer is diagnosed, don't forget, it just doesn't affect the patients only. It affects their family, it affects the children, it affects their job, finances, and their own body, the social outings, their job. So many aspects of their life is affected by the cancer. Some people, they call it like, when they heard the word cancer, their goalpost is changed, their life changes, their just a point, this was a turning point in their life. So you can imagine, obviously, as much as the support patient requires, their family, their spouse, their children, they also need good support from us.
Okay. Why did you want to become a Macmillian nurse?
Well, also my personal family reasons, because somebody in my family had the cancer, and when they came to us and told us how much they felt grateful from the Macmillian and all that, that really encouraged me to do Macmillian course. But also I was a bowel cancer screening practitioner before, and in bowel cancer screening program we diagnose the patient. And after that, we don't know, because we just transfer the patient to the surgeons, to the Macmillian and all that, and we never know what happens. But this Macmillian post really encouraged me to know and help the patient and support the patient throughout their cancer journey and to be with them.
And I guess over many years, you've probably met hundreds and hundreds of friends now, isn't it?
Yes, that's right. We normally see 400 patients a year. New patients that I'm talking about. Then we are talking about the patients who have a recurrence disease. They are unfortunate to have the cancer coming back to them. Then there are patients who are coming to our door because they are having follow-ups for 5 years. So it's a constant flow coming. And we have patients, we receive a thank you card. And there are some good stories when patients, they have complete cure, and there are some stories when patients are unfortunate, but we are with them when the end of life comes near to them as well.
If the people are interested in like finding out more information about Macmillian, have you got information here and what it does?
Well, we have brought some information with us about our information packs and all, but we provide to the patient about the colon cancer, rectal cancer, anal cancer, etc. We also provide patients information with after the treatments. We help patients with the survivorship programs. We help them, we take part in the teaching programs for the patients and for their families, and also for the staff in the hospital. We also have an information center in the hospital where patients can walk in and they ask for information if they want to.
That's right in the reception at the front, isn't it?
Absolutely, yes. Yes. And we'll also be running an awareness week like this on 29th of April. So please come in and support us.
There's a question for you as well.
It's only me. My question is, you said the only people here is cancer.
Correct.
We give the bad news to them.
Yes.
How do you think, other than the word cancer, which is a medical term, that's a term we'll have to ask them, what do you think we can use something else?
Unfortunately, it's never a better word. Never. There is never going to be a better time. Never. It's just, that's what it is.
Well, it is what it is.
That's right.
Yeah.
Yes. It's not never a better timing. Never. People they say something like, should we have done it at the time? Should we have said it differently? Unfortunately, not. That's what patients have to deal with it, get on with it, and we have to support them as much as we can.
So there's nothing else we can do from our point of view, isn't it?
Then we can be as supportive as possible and expedite their treatment as possible as we can and make their journey easier. That's what we can do, and that's what we aim to achieve.
I think you're doing a brilliant job with that.
Thank you very much.
Listen,